Great. Thank you very much, Dr. Sawyers. On behalf of all my colleagues at the National Cancer Institute, I'd like to present our data on a new type of immunotherapy that's shown activity in childhood acute lymphoblastic leukemia, or ALL. Now, ALL is indeed the most common malignancy of childhood, and great strides have been made in the past several decades in the treatment for ALL, such that the majority of patients, majority of children, are able to be rendered into a remission state. However, that comes with a price. The therapy is long. It takes often 2 to 3 years. It's toxic and it's costly. Furthermore, that's no guarantee of long-term cure. There are a significant number of these children that end up relapsing with disease, and then their therapeutic options at that point are limited and carry with them even more toxicity. So for these reasons, ALL represents, or leukemias represent, a leading cause of death due to malignancy in childhood. And therefore, new therapies are greatly needed. So one potential new therapy are T cells that have genetically been engineered to attack leukemia, or as I call them, CD19 chimeric antigen receptor, or CAR T cells. And these are based on a Tcell receptor that naturally occurs in the body. And I won't try to turn everybody into immunologists, but to briefly describe, the Tcell receptor is specific for a very specific portion of a protein that's expressed on tumor cells or on viral cells or any other foreign invader type cells that you can imagine. This interaction is very specific. It differs from patient to patient. It differs within tissues, even within the same patient, and it differs even between leukemia cell and leukemia cell. So the chances of this interaction happening in ALL is rare, but even if it does, that interaction would generate one signal to the T cell called signal 1, which partially activates the T cell. However, for T cells to be fully activated and carry out their killing function, they require a secondary stimulation signal. Here showing one type of signal called CD28. The ligands that produce these signals are often absent on ALL cells. So therefore, no signal 2 is generated in the T cell, and the T cells are not able to function adequately and control leukemia. So in contrast, chimeric antigen receptor signaling it gets around these major pitfalls in several ways. First, and principally, the T-cell receptor has been replaced by a small portion of a monoclonal antibody that in this case, in this trial, is specific for an antigen called CD19 that's expressed on the ALL leukemia cell. Once that single interaction occurs, the receptor then fires 2 signals, both signal 1 and signal 2, in the T cell simultaneously, allowing the T cell to be fully activated and then go on to kill its target. So we can make these CAR T cells in a sterile processing facility at our institution in 11 days. First, we collect the T cells from the patients. Apologize for the slide. It appears to be a little messed up. But we collect in a simple procedure in the patients. We then stimulate them for 2 days outside the body, and then genetically engineer them to express the CD19 CAR, followed by an additional 7 days worth of expansion before they're reinfused back into the same patient. And we designed a phase 1 clinical trial around this idea. And here I'll share with you our first 4 patients' results. We have enrolled a 5th patient, but he is too early to be reported this time. We have enrolled 3 patients with ALL and 1 patient with a B-cell lymphoma. We have our first 3 patients all have had prior bone marrow transplantations prior to coming to us. So they've relapsed after their bone marrow transplant. In fact, the first patient had 2 bone marrow transplants. And then we were able to achieve our targeted cell dose of 1 million CAR T cells per kilogram in 3 of our patients. In patient 2, we were only able to manufacture 28,000 CAR T cells per kilogram. But despite this, we found a rather surprising and unexpected result in that she had an early, but unfortunately transient, complete response to that therapy. Subject 1 ended up having a complete response that lasted several months. Subject 3, one with lymphoma, did have progressive disease. And probably most striking is patient number 4. She had not had a bone marrow transplant because she has never been in remission. Despite multiple rounds of intensive upfront chemotherapy, she has been completely chemotherapy refractory. And with that, she came to us. We gave her 1 million CAR T cells per kilogram, and she achieved a complete response and has moved on to subsequent therapy that hopefully will be curative for her bone marrow transplantation in this case. And this is her bone marrow, both before and then after, 24 days after a CAR T-cell infusion. You can see before there's about 30% ALL blasts, and this is evidenced by the brown dots that you see, and these are absent at day 24. So with this therapy does come some side effects, but it's important to note that not all these side effects are seen in every patient, and when we do see them, they're temporary, lasting only a few days, and they're quite easily managed in a hospital setting. Principally, we do see fever, low blood pressure, and low blood counts in these patients. Now, one particular side effect that we were concerned about when we designed this trial was whether or not we might elicit some graft versus host disease in the patients who have already undergone a bone marrow transplant. So the basics of GVH are that donor T cells, which are present already in our recipients, in our patients, react against the patient's own, the recipient's own liver, skin, and GI tract, causing clinical manifestation that's known as GVH. And I'm happy to say that in our first 3 post-bone marrow transplant patients, we have not seen any evidence of GVH in any of them. So to summarize, CD19 CAR T-cell therapy is a completely new way to attack childhood leukemia, and with it, in our limited experience so far, has manageable toxicities that are transient. CAR T-cell therapy is active against childhood ALL that's been refractory to other standard therapies, including bone marrow transplantation. And finally, this therapy can induce complete remissions even when chemotherapy cannot. Thank you very much.